Hello, everyone. For those who don't know me, my name is Trevor Cox, and I'm excited to share this week's case presentation with you. And I also wanted to wish a belated RD Day to everyone in the class and also to our professor. So, for this week's case study, we're focusing on a patient from my current clinical site of McLeod Health Seacoast with my preceptor, Miss Deanna Fisher. This patient was admitted on March 3rd for malignant neoplasma of the colon. 2 days after admission, she was admitted for surgery to remove the right side of her colon due to the malignant tumor, and while she was prepping for surgery, she was an NPO patient. This patient is an 82-year-old female with hyperlipidemia, atrial fibrillation, Parkinson's, acute hyponatremia, and respiratory failure with a post-operative ileus. She currently weighs 98 pounds with a BMI of 18. The dietitian was consulted for this patient from the physician as they are starting and wanting to start PPN at 70 mLs per hour with a solution of 4.25% of amino acid and 5% dextrose, giving the patient a total of 1,071 calories and 71 grams of protein. The patient's current minimum needs are 1,320 kcals and 66 grams of protein. The physician was factoring in a PO intake while factoring this PPN, as the formula itself would not meet her minimum needs. She is currently on a mechanical soft and chopped diet with Ensure TID. It is recommended that this patient starts a multivitamin, thiamine, and folic acid supplement to assist with the malnutrition and also to start an appetite stimulant to aid with PO intake. Looking back at her anthropometrics, we know that this patient is 82 years old, a female, at a height of 5'2", weighing 98 pounds. Her ideal body weight is 110 pounds. And since admission, 6 days to the current day, she has gained 20 pounds or 25% of her weight. However, prior to admission, it was apparent that she has been losing weight quite frequently, signifying that she has severe protein malnutrition. Looking at her lab tests, it signifies that her sodium, potassium, creatinine, and calcium are all low. And her glucose is high at 183, with a normal range of 70 to 115 for glucose. Looking at her current medication, she is on calcium carbonate to treat the hypocalcemia, also on potassium chloride to treat the hypokalemia, and also on some heart medications and some others that are not relevant to this case study. Looking at her lifestyle history, she signifies that she has 1 drink of alcohol every other week. And she's also a former smoker who used to smoke a quarter of a pack a day. Moving into her NFPE, it is apparent that she has severe malnutrition according to her food and nutrition intake in her past history, as she has signified that she has been consuming less than 25% of her daily needs according to her daughter who was in the room at bedside, and also currently consuming less than 25% for the past 6 days, signifying poor PO intake. She has had weight loss, however, in the past 6 days it signified that she's gained 20 pounds. She has also lost subcutaneous fat, as this is apparent in the upper extremities, and also loss of muscle in her clavicle region. She also has reduced strength, however, does not show signs of fluid accumulation or edema. Moving into the PES statement, the problem is the altered GI tract structure and or function, which increases nutrient needs due to the illness. For the etiology, it is the GI mass and with the status post-surgery. For the signs and symptoms, it's a loss of function of colon due to the recent surgery, poor PO intake, and BMI of 18. The following is a PES statement that I created for this patient. Inadequate oral intake related to altered GI function, as evidenced by severe muscle wasting and subcutaneous fat loss in upper extremities. The current course of action is to have the patient start with a DOPOF for nutrition support to utilize the GI, and this goes in a different direction than what the physician has recommended, as we want to go to enteral nutrition over parenteral nutrition, as this would be beneficial to using the GI tract. We are choosing to use a elemental formula due to the altered GI function. We are using Vital 1.5 at 45 mLs per hour, giving the patient 1,620 kcals and 73 grams of protein and 825 milliliters of free water, which would meet her current needs with the addition of free water flushes. And her goal diet is a low-fiber blend for 2 to 4 weeks with Ensure TID and Ensure pudding. Thank you for your time listening to my presentation, and I look forward to listening to everyone else's. Have a great day.